Welcome, dear colleagues. I am Haykanush Hambardzumyan. I am the president of Armenian Association of Obesity Prevention. I would like to express my gratitude for the opportunity to participate in this congress. My presentation is according to vitamin D impact on insulin resistance. In my daily practice, I have many patients with insulin resistance, and almost everyone has a profound vitamin D deficiency. It is too important to determine relationship between vitamin D and insulin resistance. Insulin, the most important biological action of insulin is to regulate the storage and supply of energy sources in the body. Insulin exerts a variety of metabolic and non-metabolic effects. Impairment of insulin action gives rise not only to diabetes mellitus but also to various other pathological conditions, including dyslipidemia, atherosclerosis, non-alcoholic fatty liver disease, cognitive disorders, and certain types of cancer. Insulin stimulates glucose uptake in classic insulin-sensitive tissues such as muscle, liver, adipose tissue. As a fact of the past 20 years, research in this field has identified unique actions of insulin in the brain, despite insulin doesn't stimulate glucose uptake in the brain. Mechanism of these actions in the sensitive tissues is different. In the muscle, insulin increases glucose uptake, increases glucagon synthesis, and increases special protein synthesis. And as we know, muscle account for about 60–70% of whole insulin body insulin-mediated uptake. In the liver, insulin increases glycogen synthesis, increase lipogenesis, and decrease gluconeogenesis and glucose release. In the adipose tissue, increase glucose uptake of storage, increase lipogenesis, and decrease lipolysis. So, in addition to regulating central nervous system functions, insulin has impact on prefrontal cortex, hypothalamus, hippocampus, and the effect is to improve cognitive functions, to reduce depressive symptoms, to decrease food intake, and reduce body weight. So we speak about insulin resistance, and we have to know insulin resistance identified as an impaired biological response to insulin stimulation of target tissues, primarily involves liver, muscle, adipose tissue, and insulin resistance impairs glucose disposal, resulting in a compensatory increase in beta cell insulin production and hyperinsulinemia. Genetic predisposition in insulin resistance is determined by variation in multiple genes. And in rare cases, we have the mutation of a single insulin gene, single insulin receptor gene, and we know some rare syndromes associated with mutation in the insulin signaling pathway. There are type A insulin resistance, Donahue and Rabson-Mendenhall syndromes, and the other. Several diseases are clinically associated with insulin resistance and include obesity, type 2 diabetes, metabolic syndromes, some liver conditions, heart and vessel diseases, such as hypertension, cardiovascular diseases, different types of cancer, PCOS, and other. And there is an urgent need to identify the mechanisms of insulin resistance and effective interventions for the treatment of these metabolic diseases. A relatively safe and well-accepted approach in the prevention and treatment of insulin resistance is via lifestyle interventions. Nutritional intervention is an important first step that emphasizes a low-calorie and low-fat diet that stimulates excessive insulin demands. In addition, increased physical activity is recommended to help increase energy expenditures and improve muscle insulin sensitivity. These two approaches represent the fundamental treatment for insulin resistance. The second step is the use of pharmacological medications, including metformin, thiazolidinediones, CGLP-1 receptor agonists, DPP-4 inhibitors, CGLT2 inhibitors, in some cases sulfonylureas, injectable insulin, in some cases bromocriptine, symbiotic microbiome therapy, and the other. And they are also important to understand the role of vitamin D in insulin-resistant treatment. Vitamin D is a soluble prohormone with endocrine, autocrine, and paracrine functions and is fundamental for bone metabolism, as we know. But we know that vitamin D has a significant role in extraskeletal functions too, and there is a relationship between vitamin D deficiency and some pathologic conditions, including diabetes, autoimmune disease, liver disease, cardiovascular disease, and hypertension, and cancer, and insulin resistance too. We know that most amount of vitamin D as a cholecalciferol comes from endogenous production in the skin after sun exposure, and ergocalciferol can come from dairy products and some nutritional supplements. When in circulation, cholecalciferol and ergocalciferol are converted in the liver by the action of vitamin 25 hydroxylase and converted to 25 hydroxyvitamin D3. And 25 hydroxyvitamin D3 undergoes a second conversion by the enzyme 1-alpha hydroxylase into active and bioavailable vitamin D or D hormone such as calcitriol. And this reaction takes place mainly in the kidney. At that point, calcitriol performs its function by binding to the vitamin D receptor expressed in the cytoplasm of cells, forming a vitamin D receptor and a retinoid X receptor complex. In the nucleus, this complex regulates the expression of many genes. Calcitriol has about 1,000-fold higher affinity than 25-OH vitamin D for the vitamin D receptors. And we can find vitamin D receptors in many organs and tissues such as brain, kidney, lungs, liver, joints, bones, pancreas, heart and vessels, and digestive tract and immune system. So the extraskeletal actions are available because of the presence of vitamin D receptors and hydroxylation enzymes in different tissues, such as about what we have to said. As hormonal, vitamin D supplementation has hormonal, anti-inflammatory, anti-apoptotic, anti-fibrotic activities, antioxidant, and immune modulatory effects. In detail, it was shown that vitamin D works as an epigenetic factor, fasting insulin levels, epigenetic factor affected the transcription levels of many genes involved in insulin sensitivity. And we know that vitamin D metabolism-related gene polymorphism plays significant role in vitamin D metabolic effects. About 35 genes could modulate the vitamin D serum level status. The most common gene polymorphisms described in the vitamin D binding proteins, 25 hydroxylase ferment, which can be the cause of low level of 25-OH vitamin D3, Another is 1-alpha hydroxylase, which can be the cause of low level of active vitamin D hormone calcitriol, and the vitamin D receptor polymorphism, which can be the cause of low effect of vitamin D treatment. And polymorphisms of vitamin D receptor genes are one of the most widely studied polymorphisms in relation to immune function and insulin resistance. Vitamin D receptor acts as a transcriptional factor for around 5% of human genes. Several epidemiological studies suggest a relationship between vitamin D receptor genetic variations and increased risk of obesity susceptibility. There are many meta-analyses had proven that vitamin D has shown significant effect on regulates insulin resistance, and there is a significant inverse association between serum and vitamin D levels and insulin resistance. The represented case report investigates the therapeutic impact of high-dosage vitamin D supplementation on insulin resistance and weight reduction in 16-year-old female patients who are representing with acanthosis nigricans, obesity, insulin resistance, related menstrual dysfunctions, recurrent hidradenitis, and depression. The BMI of patients was 26 and 7, and so she was prescribed metformin with no improvement of body weight and acanthosis nigricans during 11 months. High dosage weekly vitamin D3, about 100,000 international unit of vitamin D supplementation regimen was initiated. The patient exhibited gradual weight reduction -5 kilograms without keeping a special diet. During 6 months of treatment, patient had regular menstrual cycle. She didn't have recurrence of hidradenitis, and the depressive symptoms are disappeared. There was no complications associated with the high dosage vitamin D supplementation during the course of follow-up. You can see BMI, vitamin D, and HOMA-IR changes during 6 months of weekly high dosage of vitamin D supplement implementation. The patient is under observational and continue to take vitamin D at a high dose of 70,000 international units per week. Unfortunately, we do not have an opportunity to examine the vitamin D gene polymorphisms in Armenia, so genetic investigation is not provided in this case report, but my own conviction is that we can explore and identify different vitamin D related genes mutations in relation to insulin resistance and its consequences. Thank you very much for your attention.